oncologist at the Sultan Medical Military Hospital. Dr. Esam is one of senior oncologists, and it's really I always enjoying the trip with him, the scientific trip, which I mean. So in the old days before the COVID situation, and I wish those days will come back. So the mic is yours, Dr. Esam.
Inshallah, it's coming, inshallah. Thank you very much, Abdullah. Thank you, Amin. Thank you for the organizing committee and for distinguished colleagues who presented before me and who will present after me. It makes my job a little bit difficult. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning or good afternoon, sorry. We are already in the afternoon. The topic that I was assigned to talk to you today about is the duration of adjuvant hormonal therapy in breast cancer patients, early breast cancer patients, whether buying more time gives more life to these patients. These are my disclosures. Okay, so we know that hormonal therapy is the cornerstone of the management, of the systemic management of early breast cancer since long time, since the introduction of tamoxifen, which was adopted for 5 years as a routine practice. And then the question raises because of the recurrences that whether longer duration of tamoxifen would be more appropriate. And several trials have looked into that, comparing to 1 year, 2 years versus 5 years of tamoxifen, and they found that the optimal duration at that time with 5 years, which actually doubles the benefit compared to 2 years. But still, despite the huge benefit that we had with the introduction of endocrine therapy in breast cancer patients, especially postmenopausal, still those patients, they recur, and they recur in a big time. So more than half of these recurrences occur after the 5 years or the stopping of or after stopping tamoxifen. And the recurrences actually is very much well related to the ER expression. And this may indicate a long latency period for, especially in the adjuvant setting. And we know now with the introduction of the term of resistance that this may play a role in the in this matter. Some risk factors were identified, which might be potential risk factors for recurrence after 5 years of using endocrine therapy. It includes the stage, especially the nodal status, the higher histological stage, and some biological features like nowadays we know about the CDK4/6 inhibitors. And also there was some problems about the carry-on effect of tamoxifen beyond 5 years, the increased risk of endometrial cancer with the usage of tamoxifen. So the strategies would include, logically, either extending the use of tamoxifen versus switching to AI after the use of tamoxifen. The problem with that is that most of the postmenopausal patients nowadays, they are receiving AI in a way, either AI alone for 5 years or alternating or in sequencing with tamoxifen. And as Dr. Ahmed Saaduddin have indicated to you, the role of the CDK4/6 inhibitors also is rising. Earlier, extended use of tamoxifen was tested in 2 trials, the ECOG and the NSAPP-B14, and they did not actually show a clear benefit for using extended tamoxifen. There was a trend in the ECOG trial, but it wasn't significant. The studies or the approach that we're looking at is either extending tamoxifen, like in the Atlas study and the ATOM, or giving more AI after the use of tamoxifen, like the MA17 and the MA17R, the NSAPP-B42. These are the trials, and these are the hazard ratios of these trials. As you can see, there is a marginal benefit of using this approach. The Atlas trial, which looked at the use of 5 years of tamoxifen versus 10 years, and it was a double placebo randomized clinical trial, which included more than 12,000 patients, nearly 13,000 patients, who received, who were randomized 1-to-1 to receive either tamoxifen for 5 years or extended tamoxifen for 10 years. And of those, there were some patients who are premenopausal. There was a clear benefit for extending tamoxifen beyond 5 years, up to 10 years. It was statistically significant. But the interesting thing to see in this trial is that the benefit was evident just when completing 10 years. Those patients who did not complete 10 years or before the 10 years, 5 to 9 years, the benefit did not show up, and it was showed up only in patients with who completed 10 years, which raises the questions that someone will try to use 15 years and 20 years or lifelong use of tamoxifen as for diabetic medications. The other trial, which is the ATOM trial, the adjuvant tamoxifen to offer more, which had a similar design, included almost nearly 7,000 patients. And all these patients completed 4 years plus of tamoxifen, and they were opted to be randomized 1-to-1 toward either giving extended tamoxifen for 10 years or placebo. And in fact, it showed a clear benefit in terms of disease-free survival in favor of the extended use of tamoxifen, looking at the risk of endometrial cancer, which was doubled in patients who had 10 years of tamoxifen, but this did not reflect into an increase in the cancer mortality due to endometrial cancer or cancer death from endometrial cancer. And the result was updated. The meta-analysis for these trials actually have carried out that the extended use of adjuvant, there is higher incidence of hot flashes, vaginal discharge, fluid retention, higher incidence of thromboembolic event. But there was almost a significant increase in the, as I said, in the incidence of endometrial cancer, but this did not reflect into increasing cancer death due to endometrial cancer. And there was no significant reduction in death from cardiovascular disease. So almost the side effects are very similar, with a little bit superiority for the extended patients. And also, there was a clear benefit in terms of relative benefit, which was 15%, absolute benefit was 3%, and increase in mortality was 0.4%. Adjuvant tamoxifen, sorry, this is, so now we move to another approach to look at the role of the AIs in the management of breast cancer, and precisely the extended AIs. And we know that we have the MA17, which is some they call it the mother of all trials in endocrine therapy, the NSAPB42, the IDEAL, and the DATA trial. The MA17, which looked at giving patient extended an additional 5 years of letrozole who completed tamoxifen, and it's almost more than 5,000 patients, which included almost like close to 900 premenopausal patients, and 66%. This trial actually started as double placebo blind, but it was unblinded after 2.5 years of follow-up with the interim results, and 66% of women who were originally on placebo crossed over to letrozole, and this may reflect on the overall survival, of course. And there was a significant reduction in the significant improvement in the disease-free survival by 42%, and the distant-free survival or recurrence by 40%. And also there was a reduction in the new contralateral breast by 37.5%, and the established 5-year survival with letrozole was 93 versus 87. In conclusion, it was very effective, and it was almost recommended for those patients after the use of tamoxifen. The NSAPB42, which is almost a similar trial, have looked into the use of letrozole after tamoxifen, and with the same endpoints almost, and it did show an improvement for using these medication, and the same concern was shared with patients who received the full treatment. these are the details of this trial that we are going to skip. As you can see, there was no significant improvement for survival, but there was an improvement in the breast cancer-free survival, distant recurrence, and there was similar orthopedic complications. At the same time, there was no much significant increase in the incidence of the thromboembolic events. Okay. But again, we have to look into this, that the BMD was an issue here, and you need to follow your patient for their bone health. The MA17R, which another trial looked into the adjuvant letrozole beyond hormonal treatment, same almost design. It gave similar results with the superiority of giving letrozole in addition to the previous endocrine therapy, with improvement of disease-free survival, event-free survival, new contralateral breast, local regional recurrence, distant recurrence, bone recurrence, but there was no difference in terms of survival, and there was slightly added toxicity, which was not very much significant, and the quality of life of those patients were quite good according to the publication. Another approach is that patient who received sequential therapy as their initial hormonal therapy between tamoxifen and AIs. The lead trial looked into that and looked into giving extended letrozole after sequential hormonal therapy for those patients versus patient who just actually get the sequential therapy, and their primary endpoint was the invasive disease-free survival. In this trial, actually, there was a significant improvement in favor. We have to look into this. Actually, most of those patients who were included in this trial were of almost early disease. Like you can see here that the T1 was 68% of those patients. The same applies for the nodal disease, and the same goes for the histological grade. And most of these patients had both receptors positive, and almost 15% had either of the receptor positive. And most of them, they have received chemotherapy. As you can see here, that the toxicity was not very much different between the two arms, and there was an improvement in disease-free survival, which was very slight, from 77 to 74, with almost an absolute benefit of about 3%. And there was an improvement of all the other points: distant recurrence, local recurrence, secondary, and etc. In conclusion, it was an effective approach, and they have recommended it, and you have to take very good consideration of the side effects of those patients. The SOLID trial is another trial which looked into the same approach, the sequential therapy followed by extended letrozole or AIs, and there was again almost the similar absolute benefit of around 3%. This is a summary of all these trials with the hazard ratio of the disease-free survival, which was very good for almost all these trials. Finally, to conclude, before the conclusion, the NSAPP guidelines, which I'm sure that everyone is accustomed with, it did recommend that to consider further extended adjuvant hormonal therapy for post and premenopausal women in general. In my conclusion, extended endocrine therapy beyond 5 years, late recurrence are real, accounting for more than 50%. Baseline stage, grade, and other prognostic markers should be taken into consideration. Treatment pros and cons: benefit include lower distant recurrence and secondary prophylaxis. Side effects include ongoing familiar side effects. Bone health risk should be taken into consideration. When to consider this, in my view, that we should look at the stage 3, 2 with a higher risk, especially not positive. Stage 1 still need to be more personally individualized, as we are in personalized medicine. women who had tolerated previous treatment well, women who had started on tamoxifen. Finances should be taken into consideration, as well as financial toxicity. The decision is very difficult still, and which patient to choose and how to approach them. In my clinic, I usually discuss with the patient preference. We discuss the quality of life, issues of bone health, sexual life, which is a taboo in our part of the hemisphere that nobody talks about, the desire to have more children, other side effects to be taken into consideration, as well as comorbidities, previous tolerance to the medication, to the hormonal therapy, as well as the previous compliance. Benefits and economics should be taken into consideration. Thank you very much.